Welcome everybody for this presentation titled Mental Health and Behavior Interface. This presentation is jointly delivered by three of us. I'm Vikram Palaniswamy. I'm a psychiatrist specializing in intellectual disability psychiatry. I've been working in BC for the last 5 years, and during this period, I've had the pleasure of working with my co-presenters Aubrey and Michelle.
Hi there, I am Michelle Upshaw. I am a board certified behavior analyst who specializes in autism and developmental disabilities. I have been practicing as an analyst for the past 5 years and as a consultant for the past 10 here in BC. And previous to that, I have been practicing and specializing in this field in autism and developmental disabilities in Nova Scotia for the previous 12.
Hi everyone, I'm Aubrey. I'm also a board certified behavior analyst. My practice has mainly focused on adults with developmental disabilities, challenging behavior, and mental illness. I started practicing in Ontario about 10 years ago and moved to beautiful BC about 5 years ago, where I started working with Dr. Palaniswamy as part of a multidisciplinary team. And now that we've introduced ourselves, let's go ahead and get started with the first slide.
For today's training webinar, I would like to acknowledge the unceded and traditional territories in which we live, work, play, and are joining you from. Aubrey is joining us from the Musqueam, Squamish, and Tsleil-Waututh Nations. Myself and Dr. Palaniswamy are joining you from the Coquitlam, Katzie, and the other Coast Salish Peoples Nations.
We have no conflict of interest to declare. We have not been paid for this presentation, and we don't expect our remuneration to change because of this presentation. This is the outline of our presentation. To start with, we'll look at the concept of mental illness and how mental illness is diagnosed. And then we'll look into the common behavioral challenges that we would see in this population. And then we'll focus on the interface between mental health and behavior, and in particular talk about diagnostic overshadowing and the dangers of misdiagnosis. And finally, we'll look at case examples to highlight the points that we have covered.
We want you all to take a second to look at this slide and identify which of these would be attributed to a mental illness or would be attributed to a learned challenging behavior. And when you've thought about it, put your answers into the chat.
The concept of mental illness is somewhat different to the concept of physical illness. Unlike physical disorders, in mental illness, we focus a lot more on the description rather than looking into the causes. Currently, we do not have lab tests to help us diagnose mental illness. We do not have any blood tests or scans that would categorically say this is the diagnosis, although in some situations brain scans do help us point to in the right direction. The main focus in diagnosis of a psychiatric problem is the description of symptoms. We look into how long these symptoms were present, number of symptoms, the type of symptoms, severity, and we particularly look at the quality of the symptoms, focus on narrative, ask for examples, gather information from different sources, how these symptoms are present in different contexts, and look into the extent of the problem and associated features. For example, for the diagnosis of depression, we look at how long the patient is depressed. Do they have the important symptoms such as tearfulness, sad mood, loss of interest in pleasurable activities? Do they complain of easily becoming tired? Do they feel hopeless about future? Do they have suicidal thoughts or suicidal behavior? Do they have excessive, inappropriate, guilty feelings or psychotic symptoms? We also ask about their family history, how the depression developed, any environmental factors, their psychological development, and how this would have impacted their current presentation. Based on all the above information, we do ask for some tests in addition to the information that we have gathered, and this will help us determine whether the depression that they are suffering from is because of an underlying medical cause or not. For example, we might ask for a thyroid function test or a brain scan to see whether the depression could be because of thyroid abnormalities or an underlying stroke. However, the blood test or the brain scan would not tell us whether the patient is suffering from depression or not. Regarding the type of psychiatric diagnosis, there are a wide variety of psychiatric conditions. They range from intellectual disability, autism, ADHD, which are commonly seen in children, to anxiety disorder, obsessive compulsive disorder, depression, bipolar affective disorder, schizophrenia, and schizoaffective disorder, which can occur at any age. To keep it simple and make it easier for people to follow, for the purpose of this presentation, I'm going to separate the type of illnesses into developmental issues, which includes intellectual disability, autism, and ADHD, and functional psychiatric illnesses, which includes common diagnostic conditions such as OCD, anxiety, depression, bipolar affective disorder, schizophrenia, etc. In the previous slides, we looked at how psychiatric diagnosis is mainly symptom-based. In this slide, we look at three common psychiatric diagnoses: depression, mania, and dementia. Although largely the symptom criteria for the diagnosis of these conditions are the same in general population compared to people with intellectual disability, there are some differences. For example, in people with intellectual disability, irritability, aggression, refusing care are some of the symptoms that are more commonly seen in depression compared to general population. You can also see that aggression and refusing care are also symptoms that one could see in other conditions. For example, irritability and aggression are often seen in mania, and irritability and refusing care is often diagnostic criteria for dementia. As you're all familiar, irritability, aggression, refusing care could also be common features that one would see when people with intellectual disability develop behavioral issues due to a wide range of causes. Now, the issue is, how do we differentiate whether these features are because of underlying depression, mania, dementia, or due to other causes such as change in home situation, change in carers, etc. This differentiation is often extremely difficult in clinical situation. In my day-to-day practice, this is a large part of what I do along with my team, which includes behavioral therapists, nurses, occupational therapists, and other members of the multidisciplinary team. Hopefully, over the next few slides, I can give you some information that will be useful in making this differentiation. When I'm assessing someone for the presence of psychiatric diagnosis, I gather detailed history and look for certain points. Among other conditions, I look at the age of onset, because some of the conditions occur when they are young and they are unlikely to occur when they are old. For example, dementia is seen only in elderly population, and conditions such as intellectual disability, autism, and ADHD invariably manifest during childhood. The course of the illness also gives us a lot of clues about whether this is mental illness and what type of mental illness. For example, Developmental conditions like autism, ADHD, and intellectual disability are lifelong, although there could be changes to the severity of the symptomatology. These symptoms start in childhood and persist through the adulthood. However, other diagnoses such as depression, bipolar affective disorder, and psychosis occur either during the early adulthood or later and follow a fluctuating course. Most often, the way in which symptoms start, whether it's sudden, over a period of few days, over a period of few weeks or months, will also give some clues about the type of psychiatric diagnosis. Once you rule out any significant environmental or external factors, then it's unusual for behavioral problems to occur over a period of hours to days. Also, in some conditions where the onset is over several months, there is a typical pattern of development. For example, when somebody develops schizophrenia, in certain situations, few months before the actual onset of psychotic symptoms, one could see certain changes in their personality. They may also present with depressive symptoms, or they may present with what we call as negative symptoms such as extreme social withdrawal and deterioration in personality. Looking at symptom type, certain symptoms are almost specific to psychiatric condition. For example, catatonic symptoms wherein the person might stand in an unusual posture for several hours, not speak, or present with what we call as waxy flexibility. That is, they could be molded to adopt an unusual position for long periods, or often specific to catatonia and not seen in other conditions. Similarly, certain types of depressive symptoms, such as excessive pathological delusional guilt, is uncommon in other conditions, particularly behavioral issues. Some type of biological symptoms like early morning awakening, increased hypersexuality are often clues to certain conditions such as depression or mania. Other information such as underlying medical condition also helps to weigh in whether the issue could be psychiatric or not. For example, when a person with Parkinson's disease receives treatment for Parkinson's symptoms and develops behavioral issues in the context of psychotic symptoms, then a diagnosis of psychosis should be considered a strong possibility before attributing the presentation to other changes. Similarly, if a patient has Down syndrome and has significant features of low thyroid levels in their body and presents with irritability, then one should suspect depression, which is quite common in people who have significant hypothyroidism, and hypothyroidism is often a common manifestation in people with Down syndrome. Another important factor I usually take in consideration while diagnosing psychiatric disorders is their family history. If there is a strong family history of bipolar affective disorder or psychosis, and if somebody presents with irritability, non-specific changes, personality deterioration in their adulthood, I would consider a strong possibility of emerging psychosis and not just attribute this to any environmental trigger.
Challenging behaviors are actions that impair a person's ability to learn skills, engage in activities, participate in community, and or have the potential to cause harm to the person or others. Examples of this could look like hitting, kicking, pushing, biting, spitting, tearing clothing, disrobing, banging on walls or objects, yelling, screaming, threatening, using excessive profanity or other forms of gender and racial slander, stealing, property destruction, such as even the act of graffiti, self-harm, headbanging, skin picking, cutting, and walking into traffic. These are just some of the examples. When examining challenging behaviors, we do this by dividing them into two different separate classifications. The first classification is topography, which is the physical form or the shape of the behavior that's being demonstrated or presented by the individual. Common forms of behaviors include social inappropriateness, hostility or aggressiveness, damaging or dangerous behaviors, or illegal or violent behaviors. The second classification in examining challenging behaviors is called the function, or the root or the purpose or the whys behind the behavior. There are four different functions of behavior. The first is escape or avoid or delay situations or non-preferred activities or routines. The second could be to get access to things that the person wants or needs. This is also known as tangible. The third is connection with others. This is known as attention. And the final is sensory experiences. Sensory experiences can be divided into two parts. The first is self-regulation, which is when a person is overwhelmed, over-aroused, overstimulated, or in pain. And the second is self-stimulation, which is when the person is under-aroused, underwhelmed, or bored.
As mentioned in the previous slides, learned behaviors serve a purpose for the individual, and when there is a purpose, you can see patterns develop. So you might notice that the challenging behaviors occur with certain people, but not with others, that they're more likely to occur during the morning versus the evening. Sometimes you may notice that certain activities or sensory experiences, like loud noises, lights, temperature, can lead to more challenges. Being more aware of these patterns help you to identify the specific situations that set off the behavior. And often caregivers, when you talk to them, will be able to identify what it is that they do to turn on the challenging behavior, what triggers it, and what they do to turn it off. One of the initial interview questions I ask is, I have $1 million to give you. If you can turn on the challenging behavior, what would you do? Followed by, you get another million if you turn it off, what do you do? And this discussion leads into you identifying really what the payoff is. What is the individual getting out of engaging in the challenging behavior? Are they avoiding certain situations like noisy environments? Are they getting a certain response from people that help them feel connected, even if it's in a negative way? Are they getting out of having to do hard tasks? Are they avoiding uncertainty and unpredictability by getting people to maintain their own strict routines? Another thing that we look for is major environmental changes. Are there people close to this individual that have left or moved on, like staff? New people often aren't aware of the person's triggers and how to avoid them. They're not familiar with their idiosyncratic communication styles. Has there been a major change to the person's routine that in itself can be very unsettling for individuals? Another thing that you can look for is skill deficits and how they relate to the challenging behavior. Oftentimes, challenging behavior happens because the person doesn't know how to engage in an appropriate alternative. And ultimately, it comes down to teaching them what that alternative is. Sometimes it's as simple as teaching them to ask for what they need or how to engage with others. Sometimes it's teaching them how to tolerate real life situations, like waiting for things or accepting when things are not available. So taken together, we suspect that challenging behavior is learned when we can see a clear pattern. We know how to turn it off and turn it on. We have identified what the person gets out of it. We may have identified some environmental changes that have made it increase in frequency. And we notice that the person has pretty major skill and knowledge deficits. Intellectual disability, mental illness, and learned challenging behavior are conditions that interact, and teasing them apart can be very difficult. Sometimes we see situations where a mental illness diagnosis has been missed because symptoms have been wrongfully attributed to an intellectual disability. We see this for a couple reasons. For starters, baseline abnormal behavior is higher in the population of individuals with intellectual disabilities. Also, skill level is sometimes already quite low, so loss of skills are hard to detect as a symptom of mental illness. Similarly, communication difficulties and cognitive deficits make it really difficult to explore certain symptomology, like what the person is thinking or feeling. Individuals often have difficulty describing abstract, complicated experiences like guilt, shame, feeling of abandonment, or suspicion. Sometimes it's even just difficult for the person to tell you what it is that's bothering them or to explain that the way they're currently feeling is atypical for them. Also, mental illness can present itself very differently in individuals with intellectual disability, like being irritable or angry rather than presenting as having a low mood. We also sometimes see situations where a person has an intellectual disability and a mental health diagnosis, and that learned challenging behaviors are wrongfully attributed to the mental illness. It is sometimes the case that people receive secondary gains from their mental illness, which contributes to the maintenance of their symptoms. The social connections and attention gained when an ambulance is called or police are called or the person's admitted to hospital can be pretty powerful. It's also important to consider that mental illness and learned challenging behavior are not mutually exclusive. It is possible for symptoms of mental illness to set the stage for learned challenging behavior. Consider a situation where someone has a rational fear and that leads to intense patterns of avoidance. We can see that that persists even if the mental illness has been treated. Conversely, patterns of learned challenging behavior sometimes already exist prior to the development of mental illness and were subsequently exacerbated by the onset. For example, a person could have learned to engage in challenging behavior to get out of really difficult tasks, which becomes worse when low mood and energy makes those tasks even more difficult. Also, the knowledge of those pre-existing learned conditions are sometimes lost when individuals are supported by changing caregivers, who are the ones that attend the psychiatric appointments. Both of these situations are forms of diagnostic overshadowing and ultimately lead to a misdiagnosis. Vikram's going to talk more about the dangers of misdiagnosis in the next slide.
Why is Why is it important that we differentiate whether the issue is mental health or behavior? Let's look at two scenarios. Scenario 1, mental illness is missed, and because of diagnostic overshadowing, the presentation is attributed to intellectual disability issues. And scenario 2, behavioral issues are misdiagnosed as due to mental illness. Let's look at scenario 1, wherein mental illness is missed. For many psychiatric diagnoses, there are very effective interventions that are available. Often these interventions are quite specific, particularly when the severity is significant. Let's take the example of depression. Antidepressants are very effective for moderate or severe depression. Certain types of psychological interventions such as interpersonal therapy and cognitive behavioral therapy are highly effective interventions available for depression. So if depression is missed, then the patient loses the opportunity to get effective treatments. For certain other conditions like mania, psychotic depression, psychosis, catatonia, and ADHD, medications are often very effective, and misdiagnosing these conditions as behavioral problem means that we are not considering a type of intervention that is going to be effective for these conditions. Further, if the underlying mental illness is not picked up, it is well possible that these patients may receive inappropriate treatments which in themselves may have significant side effects. Such inappropriate interventions may be resource intensive, hard to implement consistently, and in that process may lead to significant distress to patient or primary caregivers, eliciting lot of conflict. In certain situations, inappropriate treatment can potentially worsen the problem and result in harm to patient or other caregivers. Consider the second scenario wherein patients' problems are misdiagnosed as due to mental illness. This again means that they are missing out on psychosocial interventions that are often first line in such situations. And as you are all familiar, psychiatric interventions do have side effects, and in particular, medications do have potential to cause immediate and long term side effects. Let's look at two case examples. These examples are intentionally chosen to be relatively straightforward. The first case is a case of Mary, who presents with mental health issue, and this was missed and wrongly diagnosed as being related to the patient's intellectual disability. And the second case is about a patient who presents with behavioral issues. Let's talk about Mary, a 50-year-old lady who was referred to my team. I have changed some demographics and clinical information to anonymize her presentation. She was admitted to medical ward and was there for several months. She was discharged and then referred to my team. Before getting admitted to the medical ward, there was a change in her accommodation. She had to move from her placement to a different home share provider. At the new placement, she was noted to be angry and abusive towards a child who was living there, and the caregivers thought that she was competing for attention with the child. She was extremely demanding of her home share providers. She was noted to present with erratic eating pattern, so she would eat her favorite meals, or if her preferred carers gave her the food, she would eat, but otherwise she would refuse to eat and was progressively losing weight. She refused to walk. She had to be moved in a wheelchair. She was passing urine and feces and needed depends. After being in hospital, she was talking only to her preferred carers and refusing to talk to others, including the doctors. She was admitted to the hospital because of her aggression and her placement broke down. She was in the hospital for several months, and during the course of the admission, she was treated with different antidepressants, anti-anxiety and antipsychotic medications, and they were largely not effective. She was extensively investigated in the medical ward. She had bloods, ECG, EEG, and a brain scan, all of which were normal. Because of her presentation, which started with the change in accommodation and her behaving differently when she was with preferred carers and refusing to talk to certain other people, and the fluctuating nature of presentation meant that behavioral issues were thought to be a cause, but she was discharged from the unit with a diagnosis of possible dementia. When we do a psychiatric assessment, we have a process of getting hold of previous charts, trying to speak to her caregivers who were caring for her around the onset of the problem, and interviewing the patient. In this process, we were able to get hold of her previous records but was unable to speak to caregivers who were providing care at the time of admission. Following a psychiatric workup, we identified that she has had histories of previous mental health issues. Some of the episodes were quite severe and she had to be admitted in hospital. We also reviewed the charts at the time of her admission to hospital and noted that her symptoms were quite consistent with a psychiatric presentation. Her symptoms were very similar to what she exhibited during her previous admissions. The way in which illness started and how it progressed all fitted in with a typical psychosis diagnosis. When I examined her in clinic, she also presented with catatonic features, which included not speaking, not eating, and not walking. We tried the first line treatment of catatonia. This did not work, and hence we referred her to electroconvulsive therapy or ECT, which was the second line treatment for catatonia. After receiving this treatment for a couple of months, she showed remarkable improvement. She reached her premorbid level of functioning. She actually had her family members living close by who were able to see and tell us that she was back to her baseline. When she became well, she was noted to be a very polite, friendly lady. She took pride in her appearance, was totally independent in her personal care, was able to walk around freely, speak in complex sentences, and was able to access community with a small amount of support from others. Over the next few months, she continued to be well, and briefly she was noted to present with increase in worries about her running out of money and that she would be thrown out of the group home. Her family members reported that in the past she has been in situations where she had run out of food and did not have anything to eat. No amount of reassurance that was given by caregivers addressed this situation. Small changes were made to her psychiatric medication, which resulted in significant improvement, and her anxiety disappeared.
So next we're going to talk about Tony. Tony's not a real person, rather he's a blend of a few different cases. So Tony is a 24-year-old man with autism, and Tony started to engage in a lot of aggression at his day program and at his house. Some brief background on Tony. He's largely non-vocal, but can use some one-word utterances. He does live with his biological parents. He's an only child, no medical issues or medication, no trauma. He's eating well, he's sleeping well. And prior to the onset of aggression, he was previously participating fully in his day program and completing tasks of daily living at home. So next we're going to talk about, we conducted an assessment which started with interviewing the parents and the day program, as well as doing a direct observation. And what we found was there was a clear pattern of behavior escalation that we were seeing. So Tony was ignoring prompts to engage in activities. When he was pushed to participate or continued to be prompted, he would begin yelling. And sometimes he would even become aggressive towards others. So it became quite apparent that the trigger or what was turning on the behavior was prompting or requesting that Tony engage in activities, whether it be at home or in the day program. And so the next thing that we looked at was what was it that was turning off the behavior? How did they get aggression to stop? And so what we noticed were parents and the day program staff would actually drop the demands when they were faced with aggression. And if they never placed any demands on him, we saw that there actually were very low rates of aggression. We also learned during the interview that Tony had a history of previous episodes of aggression. This occurred when he was transitioning into his elementary school and again into his adult services. One other piece of information that we learned was that the family had moved recently, and this preceded the onset of aggression. So it was a pretty major change for him. A new house, a new program, new staff, new peers, and his routine was pretty severely disrupted. Not in the sense that his day-to-day tasks had changed, but the environment in which his tasks were to be performed had changed. One thing we know about individuals with intellectual disabilities is that they have a difficult time generalizing their skills to new places. So we hypothesized that moving to a new setting had really increased the amount of cognitive effort that was required to complete tasks. Think back to when you first were learning how to drive a car. You really need to focus and dedicate a lot of energy to pay attention to the street signs, to remember where the brake and the gas is, to check your mirrors, to check your blind spots, to remember where it is that you're going, turning on your signals. I remember being constantly on edge until I practiced a lot, and all of those different tasks that are associated with driving became automatic, and I didn't need to think about it anymore. It was like Tony was learning to drive all over again. All of these tasks became very stressful. They required a lot more energy, and he had to learn them all at once. And so it makes sense that Tony was trying to avoid them. It was all just too overwhelming for him. So, with all of this information, we were able to develop an intervention. So, the first thing that we decided to do was to keep all of the expectations for task completion quite low. And this was to decrease the likelihood of aggression occurring in the first place. But we wanted to help Tony regain some of his independent skills that he had prior to his move. So, what we did is we slowly started to teach the tasks again. By offering lots of help, by providing reinforcement when he completed them, and slowly over time increasing the expectations until he could complete those activities by himself. One thing that we also did when aggression did occur, because sometimes we pushed him a little bit too hard, is we did not drop the demand. Instead, we taught Tony to ask for help. And then when he asked for help, we would praise him, and then we would significantly reduce the expectation. And we did this because we wanted to replace the aggression with a more appropriate behavior. And so if the aggression was serving Tony by getting him out of tasks, we felt like asking for help was a much better alternative. And the intervention worked. We saw very low levels of aggression, and Tony returned to his previous level of independence with completing tasks both at home and in the day program.
So, so in summary, mental illness and challenging behavior are common in individuals with intellectual disability. The behavioral issue that is the presenting problem could be due to an underlying mental illness or could be related to environmental and situational conditions. Sometimes it might be straightforward and easy to differentiate this, but often in clinical practice, this is complex and difficult. What can we do when we encounter such complex situations? If you routinely encounter such complex situations, it's important that you set up a team, different set of skills who can contribute to teasing out this problem and deliver appropriate interventions. I am aware of some multidisciplinary teams such as Developmental Disability Mental Health Service, which are commissioned by health authorities that have complementary skills in the team. However, often the teams are quite small and there is a big waiting list to access their service. In such circumstances, it is important that we develop a better understanding of what other members of our team do and bring to the team. For example, over the last few years, I worked very closely with some amazing behavioral consultants, and through this process, I've learned a lot about their assessments, how they approach, what they do when they encounter a situation wherein somebody presents with severe behavioral issues, learned about how they monitor outcomes, use objective outcome measures, and have tried to incorporate them in my routine clinical practice, particularly when I do not have access to behavioral consultants. Similarly, I'm hoping through such presentations I can increase the awareness and knowledge of different professionals on how psychiatric problems present in this population improve their confidence and their ability to pick up psychiatric issues and ask for assessments. Given the complexity, it is also important that we are open to different possibilities. That is, if you are delivering intervention for behavioral issues and if the intervention is not working in the way that you would expect them to work, then consider whether there could be underlying mental health issues and vice versa. If, if there is adequate interest, we are hoping to deliver more presentations in future. Those presentations would focus on how behavioral consultants and psychiatrists can work closely in this area to tease out issues, particularly when the interplay is quite complex. The focus will be how we can use our skills to complement each other and develop better intervention strategies for this population.